welcome you to this session. My name is Dr. Karen Rotuk, and I am the Medical Science Liaison for Boringa Ingelheim, operating from the Nairobi, Kenya Scientific Office. So this session is a scientific session on cardio-renal metabolic management with two planned presentations from two very great speakers. So the first speaker will take us through the evolving role of empagliflozin, which is an SGLT2 inhibitor in chronic kidney disease beyond glucose control, and we will dive into EMPA kidney data. The second speaker will discuss heart failure and highlight the European Society of Cardiology Guidelines 2023 Heart Failure Focused Updates. So before I introduce the two speakers, we will just have some general housekeeping rules. So only the host is able to see you, so the presenters are not able to see you. So in case you have any questions, you're welcome to post them in the chat box and they will be answered at the end of the two presentations. Then after the session, there will be a link that will be shared to you. Please take your time to answer just a few questions. These are going to act as the post-session survey. Now it is my utmost pleasure to introduce to you the two speakers who are going to be talking to us this afternoon. Our first presenter, and I will introduce both speakers now, and when the first speaker is done, the second speaker will just take up the presentation immediately. So our first speaker is a consultant physician, diabetologist, and endocrinologist at Kolebu Teaching Hospital, a senior lecturer at the University of Ghana Medical School. She attained her medical degree from the Kwame Nkrumah University of Science and Technology many centuries ago, and followed it with a specialist postgraduate course in the endocrinology and diabetology from Cardiff University and the University of South Wales. She has also enriched her leadership skills with a certificate in leadership and management in health from the University of Washington. And she was a recipient of the award of Best Postgraduate Presentation of Original Research by the International Society of Endocrinology, Japan. She's a fellow and member of the West African College of Physicians, American Association of Clinical Endocrinologists, Diabetes, Endocrine and Metabolic Society of Ghana, the Ghana Medical Association, the Diabetes Youth Care Ghana, and the current director of the National Diabetes Management and Research Center. Her interests in research are in infections in diabetes, prevention of complications of diabetes, and has multiple publications on the same. Ladies and gentlemen, I know by now you know who I'm talking about. It is Dr. Yacoba Atiase, who's going to be our first presenter. So on to our second presenter. We're looking forward to that first presentation. Our second presenter is a consultant physician and cardiologist with over 19 years of experience in medical practice at all levels of healthcare delivery in Ghana. His mainstay is clinical and interventional cardiology with a strong interest in coronary artery disease prevention, management, and research. His research interest is in the genomic and environmental determinants of cardiovascular diseases and has enormous skills in designing and implementing cardiovascular research in both clinical and community settings. He's a senior lecturer with the University of Ghana Medical School, College of Health Sciences, and is actively involved in the training of medical students and postgraduate students in internal medicine and cardiology. He's part of the Ghana Heart Initiative. This is a team of cardiovascular physicians and researchers who drafted the first comprehensive cardiovascular disease prevention and management guidelines for Ghana. He has attended and presented papers and topics at several local, regional, and international scientific workshops, conferences on cardiovascular medicine, and presently serves as the Vice President of the Ghanaian Society of Cardiology and the Coordinator for Postgraduate Training in Internal Medicine at the Kolebu Teaching Hospital for both the Ghana College and the West African College of Physicians. The second presenter is none other than Dr. Francis Agyekum. So at this point, it is my utmost pleasure to hand over to our first presenter, Dr. Yacoba Atiase. Thank you very much. Welcome.
Hello, good afternoon, and sincere apologies. My line dropped momentarily. Karen, thank you very much for the kind introduction, and thank you, Boehringer Ingelheim, for having me speak on the topic Evolving Role of Empagliflozin in CKD Beyond Glucose Control. The disclaimer is that everything I say here is of my view and is not necessarily shared by Boehringer Ingelheim. If I say anything, you need to cross-check before you take it hook, line, and sinker. And you have to cross-check what I say before you use it. The objective of my presentation is to discuss the role of empagliflozin in CKD in patients with diabetes and without diabetes. I will look a bit at the statistics of CKD. I'll look briefly at the relationship between CKD and cardiovascular disease. We'll look at a few definitions that we use very frequently. We'll look at guideline recommendations, have a brief look at a clinical study, clinical case and look at the EMPA Kidney Study that sought to find out the role of empagliflozin in patients with and without diabetes who have CKD. If you live in Ghana, you know that in the past 4 weeks, the issue of chronic kidney disease and dialysis has become quite topical. It has become topical because, yes, there are many patients who have CKD and require dialysis who cannot afford the cost of dialysis. And unfortunately, the price of consumables and other equipment have gone up, and so prices ought to be increased. And so it's a good time to talk about CKD, how to prevent it, how to manage it, and how to make sure that our patients do not progress when they get CKD. Let's look at a few definitions. Chronic kidney disease is said to occur when there are abnormalities of kidney structure or function present for more than 3 months with implications for health. Diabetic kidney disease, on the other hand, is kidney disease that is specific to diabetes. With diabetic kidney disease, a clinical diagnosis and is based on the measurement of eGFR, or estimated glomerular filtration rate, and albuminuria, along with clinical characteristics of diabetes, increasing the likelihood of kidney involvement. An example is if a patient is a known diabetic and has diabetic retinopathy and has had diabetes for a long duration of time, and they develop diabetic kidney disease, often would assume that is diabetic kidney disease and is diabetes causing it, and that's diabetic kidney disease. Diabetic nephropathy is the presence of a single, well-defined, identifiable kidney disease. So we are pretty sure, and we know for certain that it is directly related to diabetes. Oftentimes, we deal with diabetic kidney disease and not diabetic nephropathy. In patients with type 2 diabetes, we must also ensure that we look out for other causes of diabetes, other causes of kidney disease, because oftentimes, even though they have diabetes, it is not diabetic kidney disease. They could have multiple myeloma, they could also have lupus, they could have other causes of CKD, and so you must look out for this. But it's important to remember that 40% of patients with type 2 diabetes will develop some form of diabetic kidney disease along or during their lifetime. Let's look at the startling statistics of kidney disease. Chronic kidney disease affects approximately 1 in 10 adults, which approximates to about 850 million people. When there's CKD affects up to 40% of patients with type 2 diabetes globally, and about 20% of these patients also have heart failure, which Francis will talk about later on. Sadly, many people, 5 to 10 million people, die from CKD each year, primarily from cardiovascular disease. Because you see, CKD is associated with cardiovascular disease, and we have a few slides to discuss that. CKD is the most common reason for the progression of end-stage kidney disease in many parts of the world. And in developed countries, management of CKD is expensive, not to talk about developing countries. CKD and cardiovascular disease are closely linked. Indeed, if you have CKD and you are elderly, you are more likely to die from cardiovascular disease than to progress to end-stage kidney disease requiring renal replacement therapy. Incidentally, CKD, which is diabetes, type 2 diabetes, which is a common precursor of CKD, has the commonest cause of death being cardiovascular disease. It's important to remember that CKD, or the kidney and the heart, are so closely interrelated that a dysfunction in one organ system affects the other organ system negatively. For example, if you have kidney damage we know that can be caused by various factors. But once there's kidney damage, there's RAS activation. The RAS activation we know will eventually affect the heart, causing fibrosis, sodium and water retention, vasoconstriction, fibrosis of the heart muscle itself, and this may progress into other things. However, If you have heart failure or a heart dysfunction or cardiomyopathy of any source, it is likely that this may lead to sympathetic nervous system, dysfunction, increased venous pressure, and this will eventually lead to hypoperfusion, apoptosis, and eventually lead to glomerulosclerosis. And so these two organ systems are closely interrelated. While CKD may cause or may lead to cardiovascular disease death, the causative, the causes of the dysfunction itself are intertwined and worsen each other's prognosis. We already mentioned that CKD means that there's an abnormality in the kidney structure or function. And often we say that this must be present for up to 3 months before we call it chronic kidney disease. Therefore, to test for kidney disease, we must test for structure and we must test for function. Usually, we do this by looking at the glomerular filtration rate. The glomerular filtration rate is often quite difficult to calculate or to measure. And so we have an estimated measurement which we use by using the calculations that we know are available these days, even on apps that we can just put in the variables and calculates for us. That glomerular filtration rate calculates kidney function. Albuminuria is another way we can test for the kidney function, but that tests for the structure or kidney damage. Indeed, we say that if your kidneys are leaking albumin, it's likely that all other vessels are also leaking albumin. And so we know that microalbuminuria on its own is an independent risk factor for cardiovascular disease. There are different stages of CKD, and we know that we can measure this not only by, as we've said already, not only by the estimated glomerular filtration rate, but also by the degree of albuminuria. If you look at this slide carefully, you see that for the estimated glomerular filtration rate, it is classified from G1 to G5, with a normal GFR to where you'd say there's low end-stage kidney disease. The same way for albumin, you have mild to normal increase in albuminuria to where you have severe increase in albuminuria. And if you have both a reduced eGFR and an increase in albumin release in urine, then your risk is even higher. These are the people who are normal eGFR with normal albumin or no albumin in urine. The recommendation for frequency of visits or referral to a nephrologist will be seen. You can take a picture of this and have a look at it in your spare time. So the people who are very much at risk are those who have high albumin levels as well as a reduction in eGFR. And these are the people we must, have a look at carefully, or we must seek expert help to help us manage. Therefore, the estimated glomerular filtration rate and albumin levels and urine albumin levels can both indicate renal dysfunction, but importantly, they can also help us identify progression of kidney disease and are both useful for monitoring our patients with kidney disease, chronic kidney disease. The slide here is quite explanatory. If you have both a reduction in eGFR and an increase in albumin in urine, then the risk of mortality by cardiovascular death is even higher as you go along. This is an increase in baseline, a reduction in baseline eGFR. You see that cardiovascular death is increasing as your eGFR reduces. Of course, cardiovascular death also increases as your microalbumin levels increase. But when you have both eGFR and a reduction in eGFR and microalbumin in urine, then the cardiovascular death is even much higher. The same principle for kidney events, which means progression of kidney dysfunction. So how do we manage patients who have CKD? And this is multifactorial. It is important that we look at all risk factors in these patients. And if a patient has type 2 diabetes, you must ensure that they have good glycemic control. You must, look at all the blood pressure. If blood pressure is high, and they don't have diabetes, then a target below 140/90. But if they have diabetes, and the target is much lower, 130/80. The first line antihypertensive for these patients should be an ACE inhibitor or an ARB. And RAS therapy is suggested, especially when they have albuminuria, because it's been shown to slow down and reduce albuminuria and slow down progression. The guidelines now also suggest that, recommend that when we have diabetic kidney disease or CKD on its own, then SGLT2 inhibitors should be considered preferentially for patients with type 2 diabetes, independent of their HbA1c level. Of course, because they die commonly of cardiovascular events, it's important that their LDL be treated to target. But it's important to remember that statins should not be initiated in patients with type 2 diabetes who are treated by dialysis. So let's have a look at a few of these guidelines. In 2022, the KDIGO guidelines recommended this, and I think this is what we all do. The base and the foundation of managing patients with type 2 diabetes is lifestyle changes: smoking cessation, diet therapy, exercise when they are able to, and weight control. In patients with CKD or diabetic kidney disease, the KDIGO guidelines suggest that we do straight away go to SGLT2 inhibitors. And then if we need to add a second line agent, we consider metformin. Before then, we consider statins and RAS blockade. After you have done your SGLT2 inhibitors and probably metformin, you ought to consider GLP-1 receptor agonists, because these two have been shown to, independently reduce the rates of progression to end-stage kidney disease. And if needed, the person has had an event before, maybe antiplatelets are also necessary. But of course, blood pressure control, glycemic control, lipid management are also important in managing these patients, because we've already said that CKD patients are more likely to die from cardiovascular events than progress to end-stage kidney disease. This is quite a busy slide, but it's from the International Society of Nephrology. What they say, and I think we've said it already, is to identify risk factors in patients. Look at the risk factors. Is there hypertension? Is there diabetes? Is there a risk of, is there a history of cardiovascular disease? Is there a family history of CKD? Or, importantly, look at other causes of CKD. Do not assume that any patient with diabetes who has developed renal impairment is getting it because of diabetes. We've had many patients who have other problems. We've identified multiple myeloma, lupus, amongst other things. So do not be focused on the diabetes. Oftentimes, you may have to look a bit more and be sure that it is not caused by something else. After you have done that, you have to evaluate renal function. Look at eGFR and look at the albumin level. If your urine albumin creatinine ratio is more than 30 milligrams per gram, or eGFR is less than 60, then you know, and if this persists after 3 months, you know that you have chronic kidney disease. You make a diagnosis of chronic kidney disease. If it is just once and you retest and it is normal, you may have to keep an eye on this patient and retest at least once a year after that. We've shown this slide already. As eGFR reduces and albumin levels increase, these are the ones who are at high risk for cardiovascular events, and they must be looked at and managed appropriately. So the 2022 KDIGO guidelines say that the recommendation for SGLT2 inhibitors is for kidney disease and cardiovascular protection. SGLT2 inhibitors have been shown to have safety and beneficial, and are often beneficial in patients with CKD. So if patients are already on other glucose-lowering medication, an SGLT2 inhibitor should be added. Indeed, if it means reducing the dose of another of the medications, you do it and introduce the SGLT2 inhibitor to the current treatment regimen. The choice of an SGLT2 inhibitor should be one that has been shown and documented to have beneficial effects for kidney protection as well as for cardiovascular benefits. And the list includes empagliflozin. Once you start your patients on SGLT2 inhibitors, it is important to remember that there's often a reduction in the estimated glomerular filtration rate. When you start, you may want to test again within 4 weeks to be sure. But however, the reduction in EGFR is not an indication to discontinue therapy, because as you see from the slides, that initial drop will eventually slow down and actually improve with time. And that is what has been shown by the studies. The American Diabetes Association guidelines are similar to the KDIGO guidelines. For people with both type 2 diabetes and diabetic kidney disease, they also recommend SGLT2 inhibitors to reduce CKD progression and cardiovascular events in these patients. The Ghana Diabetes Guidelines is not yet out, but I'll give you a small preview on it. I think the Ghana Diabetes Guidelines, we will start with metformin at a low dose, and eventually, if patients can afford it, an SGLT2 inhibitor will be introduced in patients with diabetes and CKD. The important thing to remember is that in patients who have chronic kidney disease or renal impairments, you may have to reduce your dose of metformin. If your EGFR is below 45, you reduce the dose, but if the EGFR is below 30, discontinue your metformin because of a risk of lactic acidosis that is present in these patients. Then you can add your SGLT2 inhibitor. You can add it as long as your EGFR is more than 20. But if it is below 20, you do not initiate an SGLT2 inhibitor, because you remember that we've said that there can be a drop in EGFR, and that may worsen it. Okay. After that, then you can add the other medications that you have in your armamentarium, and that can be used for glucose or glycemic control. So the summary of what I've said so far: kidney disease is becoming increasingly frequent in patients with type 2 diabetes. It is associated with reduced life expectancy, but importantly, it is associated with a higher cardiovascular mortality. And so once you have a patient with CKD in front of you, do not just focus on the CKD. Remember that they have a very high risk of cardiovascular events and must be treated as such. The pathological proteinuria and albuminuria that you find in patients with kidney disease are markers of kidney disease, and actually are signs of increased cardiovascular disease as well. The systemic effects of hyperglycemia in patients with type 2 diabetes will lead to nephron loss, albuminuria, and progression of kidney disease. And so we must, in patients who have diabetes, ensure that we have glycemic control within targets. The guidelines recommend that kidney function in patients with type 2 diabetes is assessed based on glomerular filtration rate and albuminuria, so that you can have a holistic picture and provide a holistic patient-centered care for these patients. Let's look at a case scenario. 65-year-old female who's had type 2 diabetes for 10 years, has a 10-year history of type 2 diabetes. She presented to the clinic with increasing fatigue over the period of 2 months. Like I said, she has a 10-year history of type 2 diabetes. She has an 8-year history of hypertension, according to her control with medication. She says for most of her adult life, she's been overweight, and her current BMI was 30. She has a family history of type 2 diabetes in both parents and siblings. Both parents had a CVA, and one parent died from CVA, and her father, the other parent, died from kidney disease. She's currently on metformin, 1,000 milligrams twice a day, gliclazide 80 milligrams daily, atorvastatin 10 milligrams daily, and amlodipine 10 milligrams daily. On examination, there was an elderly-looking female. She was mildly pale, had mild pedal edema. Her pulse was 90 beats per minute, regular good volume. Her blood pressure was 146/90. Chest clear, abdomen normal, central nervous system was normal, and she had signs of diabetic retinopathy on fundoscopy. Her labs, her fasting blood sugar was high. If you say that a target of about 6 to 7, 8.9 is high. Her HbA1c was 8.2. Her lipids were raised with an LDL of 3.2. She had an estimated EGFR of 45 and a urine albumin creatinine ratio of 4.9, upper limit of 2. So what are the problems in this patient? Many problems were identified. She's poorly controlled with both the diabetes, hypertension, and her lipids. The main thing or something that is of interest is her family history. She has cardiovascular disease in her history. She has, no, that's not DKA. She has a history of diabetic kidney disease in her history. And she has albuminuria herself. She has diabetic kidney disease with albuminuria herself. She's overweight and she also has diabetic retinopathy. So what are the solutions for this patient? Of course, we have to delve into her lifestyle and see whether all the lifestyle changes. And when it turned out that this patient wasn't exercising at all, was eating anyhow, thankfully she wasn't smoking or drinking, but her diet and her exercise were really poor. The important thing for this patient, because her eGFR was reduced at below 45, would consider reducing her metformin dose to 500 milligrams, maybe twice a day or even once a day. It's important that such a patient be on an ACE inhibitor. So if you consider that 10 years ago she had diabetes and 8 years ago she had hypertension, at the time an ACE inhibitor should have been the first call of antihypertensive for this patient, but it wasn't given. So she needs to have an ACE inhibitor or an ARB added to her medication to control blood pressure. And importantly, at some point, because of the diabetic kidney disease that we find now, an SGLT2 inhibitor would be useful. For this patient, it's also important that we increase her lipid-lowering medication. We need to give her up to maybe a moderate to intensive, high-intensity statin therapy. Anything that can reduce her statin dose, her lipid LDL by at least 25 to 30%. And so the very least, she should be on atorvastatin 20 milligrams or even up to 40 if she can contain it. And of course, because we are introducing all these, we have to monitor her blood glucose and make sure that we are getting onto target. Remember that SGLT2 inhibitors were originally developed for diabetes. It was originally developed for type 2 diabetes, but our friends and nephrologists and our friends and cardiologists have taken over, and they probably are using these drug class of medications even more than the diabetologists themselves. So originally, SGLT2 inhibitors were developed for diabetes, but now they've been taken over by cardiologists, as Dr. Francis Agyekum will show us shortly. Now we know that we all filter and excrete blood glucose in our urine. The renal glucose threshold for most individuals will be about maybe 10 millimoles per liter. In patients with type 2 diabetes, however, we know that they have a greater propensity to hold on to their glucose, and so their renal threshold is around 13 to 14. So pharmacologically, it made sense that they inhibit the SGLT2, which is responsible for absorption of glucose, so that when blood sugars are high, it is not absorbed properly because the SGLT2 is inhibited at the proximal tubule, and it's excreted or is excreted in urine in terms of glucose. For this reason, patients with type 2 diabetes or patients when they go on SGLT2 inhibitors are likely to lose a little bit of weight because they lose calories in urine, and even that they may even have a little drop in blood pressure. But it's not used as an antihypertensive. So SGLT2 inhibitors will reduce intraglomerular pressure. SGLT2 inhibitors will reduce the hyperfiltration that is often present in patients with type 2 diabetes, causing damage to the glomerulus. And because there's a reduction in hyperfiltration, there's often a reduction in albuminuria, and this may eventually slow down the progression of patients. This has been shown to be present in patients both with diabetes and without diabetes. And so that is why the guidelines have changed to the extent that diabetes is not only in patients with diabetes who have kidney disease that we give SGLT2 inhibitors to. The reason why we give SGLT2 inhibitors to patients with and without diabetes will be seen in the next few slides. And I'd like to introduce the EMPA Kidney Study. The EMPA Kidney Study was a big study, a randomized control study in 8 participating countries, unfortunately none from Africa, but the patients were distributed across Europe, Asia, and North America. These were the inclusion criteria for the EMPA Kidney Study. Patients who were more than 18 years old, who had evidence of CKD at risk of or were at risk of kidney disease progression, defined by 3 months, persistent reduction in EGFR for 3 months, and below 45 or below 90, clinically appropriate doses of single agent of RAS were there. They were on RAS, renin aldosterone inhibitors. They excluded patients who were already on SGLT2 inhibitors, patients who had type 2 diabetes and had prior atherosclerotic cardiovascular disease, people who were receiving combined ACE and ARB treatment. And I must say that is not allowed anymore. In the past, people used to do that, but now the evidence is that we don't do both ACE inhibition and ARB blockade. Any patient who was on intravenous immunosuppression therapy was also offered. Patients who were on maintenance dialysis, who had polycystic kidney disease, or who had type 1 diabetes were also excluded from this study. After a run-in period of about 8 to 12 weeks, the patients were, these are patients with and without diabetes who have CKD. They were randomized into empagliflozin 10 milligrams daily, plus the standard of care, and a placebo with the standard of care. It's a multinational study, it's randomized, double-blind, and was placebo-controlled in patients with or without diabetes with chronic kidney disease. And the patients were followed up with a median follow-up period of about 3.1 years. And the study was event-driven, and the study ended when we had more than 1,070 patients with events. What was the primary endpoint? The primary endpoints were cardiorenal composite outcome time to first occurrence of kidney disease progression or end-stage kidney disease, and when there was more than 40% drop in EGFR from randomization, or 2, when there was cardiovascular death. I will not go into the cardiovascular part of the trial. I'll look at the kidney section. Okay. So I think we've done this. The composite outcome were kidney progression or cardiovascular death, but I said I won't go into cardiovascular disease. The kidney progression was anybody who had a sustained reduction in EGFR for more than 40% and an EGFR, end-stage kidney disease, less than 10. Remember the slide I showed you earlier? Well, it's good to have a look at it again. The EMPA Kidney Study took patients who were within this side of kidney disease. They had a significant reduction in EGFR, and they had also microalbuminuria. You can see that we've tried to highlight it here. So some of them had very little normal to mildly increased albuminuria, but importantly, they all had a reduced EGFR, and across the spectrum of albuminuria, the patients were chosen from mild to normal, normal to mildly increased to severely increased albuminuria. There were over 6,600 participants, and like we said, they were randomized into empagliflozin and placebo arm with standard of care. A few of the patients withdrew as was expected, but most patients stayed. Over 99% of patients stayed in both the EMPA arm compared to the placebo arm. So let's look at the results. As you can see, the patients were similar across age, sex, history of diabetes or without diabetes, kidney disease in terms of cause of kidney disease. They used diabetic kidney disease, patients with glomerular disease, patients with just hypertension or renovascular kidney disease. And the GFR, we said the mean GFR was less than 30, was similar across categories. And the mean albumin creatinine ratio was also there, similar across categories. The ages, the ethnicity, and the regions were also similar. This is a summary of the patients. 54% of these patients had no history of prior diabetes. 27% had a history of cardiovascular disease, and 35% had an EGFR less than 30, and 48% had an EGFR, urine albumin creatinine ratio less than 300. So let's look at the results again. Within a year of starting, remember we said that the mean duration of a study was about 3 years. Within a year of starting the trial, you can see the separation of the curves, and you can see that the patients with who were put on empagliflozin had better outcome of a primary composite event, which was kidney progression or cardiovascular death. And so empagliflozin was shown to be useful in preventing kidney progression or cardiovascular death in patients with kidney disease with or without diabetes. The kidney progression arm can be seen here. It's much wider than the cardiovascular death. And so for the EMPA kidney, we'll emphasize its effect on kidney function and kidney progression. All-cause hospitalization was also reduced as a relative risk reduction of 14% of all-cause hospitalization in patients who are on the empagliflozin arm compared to the placebo arm. The composite results, cardiovascular death or kidney disease progression was reduced by 28% and all-cause hospitalization by 14%. The subgroup analysis show that for patients who had a baseline EGFR of less than 30, empagliflozin was favored. It did better. Patients who had very severe, I'm sorry, the footnotes have eaten into the study, but you realize that the patients who had higher amounts of albuminuria did even better compared to those who had mild to moderate albuminuria in terms of the use of empagliflozin. Across the spectrum of what the cause of kidney disease was, empagliflozin was favored over placebo. Depending on what the baseline HbA1c was, empagliflozin was favored. And whether or not they were on RAS inhibition, empagliflozin was also favored compared to the placebo arm. And this is a slide I mentioned earlier, that it's expected that your EGFR will drop slightly or significantly in patients who start on SGLT2 inhibitor. But the long-term effect of being on the SGLT2 inhibitor makes it more important, because the slope now levels out and eventually crosses, which means that the people who are progressing more when they're on placebo compared to the empagliflozin. And that's what I was saying. The slope is much better in patients who are on empagliflozin compared to those who are on placebo. Yes, every drug comes with side effects. And so they looked at the side effects. We know that because empagliflozin or the SGLT2 inhibitors cause a secretion or a release of glucose in urine, there is a risk of UTI and mycotic infections. But if you look at the safety outcomes in this patient, it was quite similar in the placebo-controlled arm compared to the empagliflozin. The risk of genital infection was also similar. The risk of hyperkalemia across board was similar. I think it was only the ketoacidosis that there was a slight increase, but you must choose your patients carefully. As I draw the curtain on my presentation, I'd like you to remember why DKA and diabetic kidney disease and dialysis has become topical in Ghana in the past few weeks. This was a notice that was put up by the head of unit of the dialysis unit, that the cost of dialysis had been increased from 380 cedis overnight to 765 cedis. It's important to remember that diabetic kidney disease, or CKD of any cause, is debilitating to the patient. It reduces the quality of life. It increases their risk of mortality. It changes families because it's expensive. But importantly, we have work to do, because we can reduce the risk of who gets chronic kidney disease. In my final slide, I think we have the onus lies on us to prevent CKD in the first place. And this we do by reducing all the risk factors in patients who have diabetes, hypertension, lupus, whatever cause of CKD may be. It is for us to identify it and prevent it from progressing. However, when CKD has already started, we also have a role to play. We have to choose medications that can reduce the progression to end-stage kidney disease, because that is when the cost becomes debilitating. Thank you for your attention. I'm available for questions after this. Thank you very much.
Thank you very much, Dr. Atiase. That was a wonderful presentation. You have really taken us deep into chronic kidney disease, right from the definitions all the way to a very brilliant study, the EMPA Kidney Study that was done, which had tremendous positive results. Now, it is my pleasure to welcome Dr. Francis Agyekum, who will take us through the next and the last part of this session. Welcome, Doc.
Thank you very much. And good afternoon to you all. This afternoon, I'm happy to be presenting on the same platform with my boss, Dr. Atiase. Dr. Atiase, thank you for such a wonderful presentation. In the next few minutes, we are going to be looking at heart failure management, ESC guidelines in the heart failure management. We will be looking at the unique role of SGLT2 inhibitors in heart failure. The main objectives for this afternoon will be to discuss the unique role of SGLT2 inhibitors in heart failure management across the spectrum of ejection fraction, and also to discuss the new guidelines for the management of chronic heart failure. The main focus will be the update, but of course, since we are discussing heart failure, it has to be comprehensive, and I'll take you through the other guidelines that have been released as well. The management of heart failure has evolved over the years, and it keeps evolving very rapidly, especially with respect to new medications that have become available as part of the armamentarium to the management of heart failure. There's extensive data that has been published over the last 6 years, and this has sort of forced several international societies to either release new guidelines, update their guidelines, or do a focus update on their guidelines. I mean, to amaze you that the latest ESC guidelines for heart failure was released in 2021, barely 2 years ago. Usually it takes about 5 years for them to bring a new guideline, but this time around, just this the end of August, early September, they brought a focus update. So that tells you how rapidly the terrain is changing, and we all need to update ourselves with that. One of the major achievements or landmarks that have been done in the area of heart failure is the latest publication of a consensus sort of universal definition for heart failure in 2021. And this was an extensive work that involved the American Heart Failure Society, the Heart Failure Association of the European Society of Cardiology, the Japanese Heart Failure Society, also endorsed by the Canadian Heart Failure Society, and several other societies, all the big societies around the group. And now we know the definition of heart failure as a well-accepted definition by all of us, like a clinical syndrome, which is characterized by symptoms and signs that result from structural and or functional abnormality of the heart. And this is corroborated by either elevated natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. This definition is now universal and accepted by all these major guideline societies I mentioned. The main thing is when we say there is structural abnormality of the heart or functional abnormality of the heart, we are looking at things like cardiac enlargement, left ventricular hypertrophy, or ventricular dilatation, and then systolic dysfunction or diastolic dysfunction. And then, of course, we know we have cutoffs for BMP and pro-BMP, which are the major natriuretic peptides that are measured in the diagnosis of heart failure. So either you have these abnormalities corroborated by this elevation in natriuretic peptides or objective evidence of pulmonary or systemic congestion. We are also very much aware of the classification of heart failure based on ejection fraction, and this is very, very important when it comes to the management of heart failure until, of course, the SGLT2 inhibitors came in the picture. So we have heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. And these are not the same. There are some differences among them. When we say somebody has heart failure with reduced ejection fraction, of course, there are signs and symptoms of heart failure, and the ejection fraction measured by either echocardiography or cardiac MRI or any other imaging modality is less than 40%. And if the ejection fraction is between 41 to 49%, we say that this person has heart failure with mildly reduced ejection fraction. Then those with preserved ejection fraction, these are the difficult ones to diagnose. They have signs and symptoms consistent with heart failure, but their ejection fraction is normal, about 50%. So in addition to this, you need objective evidence of cardiac structural or functional abnormality, as I've already mentioned. And the more abnormalities you have, the more likely or the higher the probability of making that diagnosis of heart failure with preserved ejection fraction. And as I've already mentioned, they are of different characteristics. Heart failure with preserved ejection fraction tend to be more common in elderly patients. People, as we age, we tend to be more likely. It is also more common in people who have atrial fibrillation, more commonly associated with hypertensive heart failure, more commonly associated with people with chronic kidney disease, but they tend to have less elevations of natriuretic peptides. And if people develop something like ischemic heart disease, they are more likely to have heart failure of reduced ejection fraction than heart failure with preserved ejection fraction. So these categories are not the same, and that is why management of these different types of heart failure should also not be the same. Another important thing when you talk about heart failure is the mortality that is associated with heart failure. Indeed, the mortality of heart failure is very high. It's the 5-year mortality is close to 50%. What that means is that when you diagnose people with heart failure in the next 5 years, just about half of them will be alive. And whether the people have symptoms of New York Heart Association class 1 or 2 or 3 or 4, the mortality is high. Within 3 years, 34% of patients who have New York Heart Association class 1 and 2 and 42% of patients who have New York Heart Association class 3 and 4 will die. And that is why we need to be able to reduce mortality when it comes to heart failure management. If you take the mortality associated with heart failure, it is higher than the mortality associated with many other deadly conditions we will talk about. Look at the mortality associated with breast cancer. The 5-year death rate is about 10%. That of Hodgkin's lymphoma is about 14%. That of colon and rectal cancer is about 34%. And look at heart failure, we are looking at 48%. That is why every effort must be made to reduce this deadly disease. Another thing about heart failure is we know it's a chronic condition and it is interspersed with acute episodes. So patients with heart failure tend to get frequent recurrent hospitalizations. And the bad aspect is every hospital admission for heart failure leads to worse outcomes, leads to increased mortality, leads to reduced quality of life for these patients. So reducing hospitalizations is also a very important endpoint for heart failure management. Not only does it improve the quality of life, it also reduces the mortality associated with heart failure in the long run. So this slide shows that repeat hospitalization for heart failure is associated with increased mortality. So if you take somebody who has had just one hospitalization for heart failure compared to somebody who has had a fourth hospitalization for heart failure, there is indeed a significant reduction in the survival among those who have more heart failure admissions. Now, let's look at the evolution of SGLT2 inhibitors in the management of heart failure. Then we will come back and look at the whole management of heart failure. As Dr. Atiase earlier on mentioned, SGLT2 inhibitors are anti-diabetic medications. They were discovered as anti-diabetic medications. And as part of the requirements, you needed to demonstrate cardiovascular outcomes with all new diabetes medications that were being produced. So these were then done. And the first one was the EMPA reg outcome that demonstrated significant reduction in 3-point MACE with empagliflozin versus placebo in patients with type 2 diabetes. So then it started raising some interesting questions there. So the question were, are the benefits similar in patients with and without heart failure at baseline? And were these chance findings, or could they be replicated with other molecules in this same group? So further studies were done, and these findings were duplicated in other SGLT2 inhibitors. So then the issue is, now we know that not only are they anti-diabetic medications, but they also reduce heart failure, and they can also be used in the management of heart failure. So the next question was, how confident are we that SGLT2 inhibitors treat heart failure versus prevention of heart failure events in diabetes? Do these agents work in patients who also don't have diabetes? Because this was just studies that were limited to patients who have diabetes. So now we know that they are preventing heart failure. Could they treat heart failure? And could they treat heart failure in patients who also don't have diabetes? And that is when several studies also started coming up. And we will take you through one or two of them to see how they demonstrate the efficacy in the management of heart failure with reduced ejection fraction. So the first was the DAPA-HF trial, where the primary outcome was a composite of cardiovascular death or heart failure hospitalization or urgent heart failure visit to the emergency room. And there was a significant reduction, about 26% reduction in the primary outcome with those who were on SGLT2 inhibitor dapagliflozin versus those who were not on SGLT2 inhibitor. And these are patients who were on treatment for heart failure. When we say placebo, it does not mean that they were given water injection. They were on all heart failure medication that were available at the time, with the exception of the SGLT2 inhibitor. And so on top of this optimal medical therapy, it showed a significant 26% reduction. And there was also a significant reduction in cardiovascular death, about 18% reduction in cardiovascular death. And this was replicated in the EMPEROR Reduce trial. So EMPEROR Reduce also similar composite endpoint of cardiovascular death and heart failure hospitalization. There was a significant reduction, 25% reduction in the composite endpoint, and there was also a significant reduction in recurrent hospitalization. Note, and remember that I said that recurrent hospitalization is one of the major endpoints that you want to achieve in your management of heart failure. So these SGLT2 inhibitors were very effective. And what is important about these two trials is that it is not only the diabetics who benefited from it, those who did not have diabetes also benefited from it. So we then know that SGLT2 inhibitors are not just anti-diabetic medications, but they are indeed heart failure medications. And there was no signal that those who had diabetes benefited more than those who did not have diabetes. The benefit was similar in both groups. So there was a meta-analysis of these two trials that was done to show the benefit of SGLT2 inhibitors in patients with heart failure of reduced ejection fraction. And as you can see, significant benefit in favor of the SGLT2 inhibitor if you combine these two trials. If you take a look at the CV def, there is also significant reduction in CV def, benefit in favor of SGLT2 inhibitors compared to placebo. Remember, I said placebo does not mean just water, but it means that they were on optimal therapy apart from the SGLT2 inhibitor. Then there were a bit of concerns that were raised because of the early drop in EGFR, but long term, you realize that they are actually kidney protective, and Dr. Atiase has gone through all this, so I'm not going to belabor the point. Another trial that shows significant benefit with SGLT2 inhibitors is the Soloist trial. This was people who had heart failure and had recent admission as a result of acute decompensation of heart failure. After the initial stabilization, they were put on SGLT2 inhibitors. And this was patients who cut across the ejection fraction spectrum. 21% of them had ejection fraction more than 50%, and about 79% of them had ejection fraction less than 50%. And all of them show significant benefit. The event rates were lower in patients who had heart failure, who were put on sotagliflozin, which is another SGLT2 inhibitor, compared to those who were not put on the SGLT2 inhibitor. So this then actually gives a clue as to SGLT2 inhibitors being beneficial in heart failure across the ejection fraction spectrum. So now we have major studies, dapagliflozin in DAPA-HF, empagliflozin in EMPEROR-Reduced, and sotagliflozin in Soloist trial, all showing that SGLT2 inhibitors are heart failure medications and they show benefit in heart failure with reduced ejection fraction. So that is not a question. Then you look at their effect on the quality of life as well. And there's a significant improvement in the quality of life. 5-point Kansas City cardiomyopathy questionnaire. That is an assessment of health-related quality of life in patients who have heart failure. And it shows a significant improvement in patients who were put on either dapagliflozin or empagliflozin, or let me just say SGLT2 inhibitor. So not only are they reducing your death rate, not only are they reducing the rehospitalization rate, they are also improving the quality of life for patients who have heart failure. And that is another important management outcome all of us are looking for. Even if patients must die, they must die happy. So it is important that whatever we do, we try to improve their quality of life. So now we've seen that SGLT2 inhibitors are beneficial in patients with heart failure of reduced ejection fraction, and multiple studies have shown that, randomized controlled trials, meta-analysis, and there's no question in our minds. So the next thing is about SGLT2 inhibition in heart failure with preserved ejection fraction. Do we have any evidence to that? Yes, there is. If you look at the pathophysiology of heart failure of preserved ejection fraction, it is not the same as the pathophysiology of heart failure of reduced ejection fraction. There are several mechanisms that are involved in heart failure of preserved ejection fraction. oxidative stress, inflammation, fibrosis, cardiac remodeling and hypertrophy, myofilament stiffness, impaired energetics, ionic imbalances. All these are at play in patients who have heart failure with preserved ejection fraction. And when you take a look at the mechanism of SGLT2 inhibitors, you realize that they are tackling these mechanisms at multiple levels, and no wonder they are showing benefit in heart failure with preserved ejection fraction. So SGLT2 inhibitors tend to improve the nitric oxide soluble guanylate cyclase pathway, and that tends to reduce oxidative stress, reduces inflammation, and its associated detrimental effects. They tend to improve metabolism and the energetics of the myocyte, reduce renal deterioration, as Dr. Atiase has mentioned that already, increase autophagic flux, improve diastolic function. So all these are effects of SGLT2 inhibitors, not just about glucose reduction. And that is why they are beneficial in patients, and they are expected to be beneficial in patients with heart failure with preserved ejection fraction. If you take one of the disease conditions that has been known for years but still eluded therapy over the years, is heart failure with preserved ejection fraction. We have had a lot of challenges in its management, right from the ditch trial in 1997 with digoxin. It did not show any benefits. Hazard ratio 0.99, no benefit at all in the use of digoxin in patients with heart failure with preserved ejection fraction. If you look at the ARBs, we have the CHAM preserved trial, the ebisatan trial. They did not show significant benefit in patients with heart failure with preserved ejection fraction, unlike patients with heart failure with reduced ejection fraction. So ARBs have not also shown significant benefit. Take a look at the mineralocorticoid receptor antagonists. So they did not show any significant benefit. Hazard ratio 0.89, crossing the unity line, telling us that there is really not much benefit. The latest one to come on board was the the Paragon trial that was published in 2021. We were so hopeful that it was going to be beneficial. By the end, it missed the end point with confidence interval crossing the unity line. Did not show significant benefit. So all the guidelines maintain these medications as may consider, because we did not really have strong evidence to recommend them as first-line therapy. Then comes the SGLT2 inhibition trials, which are showing significant benefit when it comes to heart failure with preserved ejection fraction. The first one was the EMPA Preserve trial, which was the first randomized controlled trial to show benefit of SGLT2 inhibitors in heart failure with preserved ejection fraction. The primary endpoint was a composite of cardiovascular death or heart failure hospitalization. And it led to a significant 21% reduction in the primary endpoint. And the number needed to treat was only 31, which is very significant. So for the first time, we had an agent showing significant benefit in patients with heart failure with preserved ejection fraction. And this benefit was mainly driven by heart failure hospitalizations, leading to significant reduction in heart failure hospitalization. There was not much reduction in cardiovascular death. So this, and don't forget, sometimes people tend to look at it, oh, okay, it's just hospitalizations. I think this afternoon I've demonstrated to you that heart failure hospitalization is a significant landmark to look at. It's a significant endpoint for you to consider when you are managing patients with heart failure, whether heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. If you take a look at the subgroup analysis of the EMPA Preserve trial, you realize that across the spectrum of ejection fraction, the SGLT2 inhibitor, empagliflozin, was significant and showed significant reduction in the heart failure hospitalizations, all the way to ejection fraction about 60%. So this is one medication that shows significant benefit in heart failure. Then, if you take a look at the soloist trial, as I've already mentioned, they also had people, some of them, 21% of the patients having heart failure with preserved ejection fraction. And whether the ejection fraction was below 50% or above 50%, there was significant benefit with the use of SGLT2 inhibitor, sotagliflozin. Then came the DELIVER trial, which is another landmark trial, randomized controlled trial of an SGLT2 inhibitor in patients with heart failure with preserved ejection fraction. Similar outcomes with the EMPEROR Preserve trial, and they show significant benefit as well in patients with heart failure with preserved ejection fraction, mainly driven by heart failure hospitalization, reducing heart failure hospitalizations, not so much of reducing mortality. So this was a meta-analysis looking at the DELIVER trial and the EMPEROR Preserve trial, and you realize that there's a significant benefit in favor of SGLT2 inhibitors in patients with heart failure with preserved ejection fraction. So for the first time, we have an agent that is having robust evidence in support of its use in heart failure with preserved ejection fraction. The EMPULSE trial was also another one that shows significant benefit, efficacy, and safety of SGLT2 inhibitors in hospitalized patients with heart failure irrespective of the ejection fraction. So whether they had reduced ejection fraction or they had preserved ejection fraction, they benefited from the empagliflozin agent that was used. And this, they used the win ratio analysis method. So if you see a blue line, it means that it is in favor of the empagliflozin. And all the endpoints, you take a look at them, time to death, clinical benefit, all of them, you realize that it is in favor of SGLT2 inhibitor. So whether you have reduced ejection fraction or you have preserved ejection fraction, you will benefited. Another question, clinical question that usually comes to mind is, if you take a look at the Paragon trial, people who had ejection fraction below 45% tended to have some benefit, but those whose ejection fraction were above 45% did not show any benefit. So these researchers, they released this paper just this year. They tried to compare, they took patients at the patient level, same ejection fraction, compare the ANI, sacubitril/valsartan, with SGLT2 inhibitor at the same ejection fraction levels to see which one was more beneficial. And they look at various outcomes, cardiovascular death and heart failure hospitalization composite, and you realize that the empagliflozin led to more reduction in this compared to the sacubitril/valsartan. If you take a look at time to first hospitalization for heart failure, empagliflozin showing significant benefit compared to sacubitril/valsartan. So the point is the magnitude of the reduction in the risk of serious heart failure outcomes appears to be greater with sodium glucose cotransporter 2, that's SGLT2 inhibition, than with neprilysin inhibition for most patients with heart failure with preserved ejection fraction. And this should put to rest when it comes to management of heart failure with preserved ejection fraction. And all these trials I've taken my time to take you through have informed several of the guidelines for heart failure management that I'll be taking a quick look at and then bring the curtain to a close. So now when it comes to the new guidelines for the management of heart failure with reduced ejection fraction, there are 4 foundational drugs, the 4 building blocks for treatment. And as much as possible, most patients with heart failure with reduced ejection fraction should be on these 4 foundational drugs, either RAS inhibitor or ACE inhibitor or ANI, with preference for the ANI if the patients can afford and the patients can tolerate, or ACE inhibitor. If they cannot tolerate ANI or ACE inhibitor, then you replace that with a RAS blocker. Beta blocker should be one of your foundational drugs. And the beta blockers, the 4 beta blockers that have been approved for use are carvedilol, metoprolol, bisoprolol, and nebivolol. Please don't go and prescribe atenolol and propranolol in heart failure. These have not been approved. Only 4 beta blockers that have been approved in heart failure. Mineralocorticoid receptor antagonists also form part of your foundational therapy for patients with heart failure. And it is either spironolactone or eplerenone. Eplerenone is more specific, less gynecomastia compared to spironolactone, but of course, more expensive than spironolactone. So depends on your patient's pocket. SGLT2 inhibitors, 2 of them have been approved for use in heart failure, empagliflozin and dapagliflozin. So these 4 pillars are what you are looking out for in all patients with heart failure with preserved ejection fraction. And this is consistent across all the heart failure guidelines. European Society of Cardiology, American Heart Failure Guideline, the Canadian Society, Australian, all of them. This is consistent. And when you come to the Ghanaian Society of Cardiology guidelines we release, cardiovascular guidelines, it is also consistent with this management. Of course, you have to look at your patient, their affordability, and things like that. Historically, heart failure management was like, okay, starts from ACE inhibitor. If they are not tolerating it, change to ARB, add a beta blocker. If they are still symptomatic, add mineralocorticoid receptor. It took years and months for you to be able to achieve optimal therapy for your patients. And this was not based on science. It was based on what was discovered first. And so ACE inhibitors were discovered first to be good in heart failure, therefore start with them. And then beta blockers. And then mineralocorticoid, there was no scientific basis for this order. Now the paradigm has changed. So the new paradigm, the contemporary approach to the treatment of heart failure with reduced ejection fraction is that you need to initiate all these medications at the same time. They are foundational therapy. And your aim is to be able to achieve at least 50% of the dose quickly for drugs that need up titration. SGLT2 inhibitors do not up up titration. So there you start 10 milligrams, whether it is empagliflozin or dapagliflozin. But your aim is to be able to have patients on all these 4 medications within at most 4 weeks, not more than 4 weeks. So you try as much as possible, initiate them inpatient and optimize them, see them early at the clinic and optimize the therapy so that you can have them on all these 4 medications. It is not about patient is still symptomatic or not symptomatic before you continue or add another one. So now the paradigm is about rapid sequencing of medications. We also know that it is not every patient who can be initiated on all these 4 medications. Sometimes their blood pressures are a little low, you are struggling with that. Sometimes there are other comorbidities that may not permit you to start all these 4 medications. So we say that if that is the case, then you have to go by the rapid sequencing. And what has been shown is you want to start all these medications within 4 weeks. So you could start with a beta blocker and SGLT2 inhibitor as your step 1, and then you add angiotensin receptor or neprilysin inhibitor or ACE inhibitor as a step 2, and then you add your mineralocorticoid receptor antagonist as your step 3. But all these must be done within 4 weeks, and depends on the patient characteristics. These are not fixed. If the patient is such that you cannot initiate a beta blocker, don't say that Dr. Agyekum says step 1 is beta blocker, and therefore I must by all means start a beta blocker. You need to look at your patient and tailor your management according to the patient characteristics. When you have gotten your patient on all these 4 medications, depending on the patient's characteristics, there are other medications that may be appropriate for heart failure management. And there's no time to go through the evidence for all these medications, but ivabradine, vericiguat, digoxin, hydralazine, potassium binders, anticoagulants, depending on the patient characteristics, iron infusion, all these may be necessary for patients with heart failure with reduced ejection fraction, sorry. Now, what about heart failure with mildly reduced ejection fraction? This is the American Heart Association, American College of Cardiology, and the Heart Failure Society of America guidelines. And this was based on the time where only EMPA Preserved had come out. The DELIVER trial had not come out yet. And so you realize that they upgraded SGLT2 inhibition to 2A. All the other agents, ACE inhibitors, ANI, MRA, evidence, they are all at 2B, may consider. Then SGLT2 inhibitors came to should consider in heart failure with mildly reduced ejection fraction. And this was similar to heart failure with preserved ejection fraction. Then came the new guidelines from the European Society of Cardiology recently, this year, ending of August, early September. And they updated the 2021 guidelines based on new evidence that had been made available. So they looked at heart failure with mildly reduced ejection fraction, heart failure with preserved ejection fraction, and they also look at a few aspects in acute heart failure and comorbidities. Time will not permit me to do all that, so this afternoon I'm just doing heart failure with mildly reduced and preserved ejection fraction. Now we do know that SGLT2 inhibitors are effective across the spectrum of ejection fraction, whether reduced, mildly reduced, or preserved ejection fraction. And this has also been demonstrated in other trials as well. I've mentioned the EMPA Preserved and EMPA Reduced and the EMPA Preserved. This was a patient data pooled analysis to look at it, and across the spectrum of ejection fraction, you see that SGLT2 inhibitors are beneficial all the way to ejection fraction of 65%. So that is very instructive. Then there was also patient level data analysis for the DAPA trials, the DAPA HF and the DELIVER trial, and similar results were found that the SGLT2 inhibitor dapagliflozin was effective across the spectrum of ejection fraction. So these are very important aspects for us to know. Therefore, the new guidelines for European Society of Cardiology came back and they updated for heart failure of mildly reduced ejection fraction. For the first time, we have a green box, which means that it is recommended. This is no longer you should consider or may consider. So for patients with heart failure of mildly reduced ejection fraction, directives for fluid retention is a class 1 recommendation, level of evidence 1. The same with dapagliflozin or empagliflozin is recommended class 1 recommendation, level of evidence A. An SGLT2 inhibitor, DAPA or EMPA, is recommended in patients with heart failure of mildly reduced ejection fraction. And the risk of heart failure, you are trying to reduce the risk of heart failure, hospitalization, and CV death. Then it comes to heart failure of preserved ejection fraction, and it is so the same class 1 recommendation. Now we have 3 green boxes, and that is very good news for us cardiologists. We have struggled with heart failure of preserved ejection fraction over the years. Now we have 3 green boxes: diuretics for fluid management, DAPA or empagliflozin for all your heart failure with preserved ejection fraction. And it does not matter whether they have diabetes or not, they still benefit. And then treatment for etiology and other comorbidities. If they have diabetes, manage it. If they have CKD, manage. If they have atrial fibrillation, manage. All other comorbidities that are associated with it, manage them. And these are very important aspects of your management of heart failure. There are several comorbidities. Time will not permit us to go through, but as I said, atrial fibrillation, heart failure, consider, are you doing rate control? Are you doing rhythm control? Are you doing anticoagulation? It's important to consider all these aspects. Hypertension, you need to manage them well. No antihypertensive that are not to be used in heart failure. Antihypertensive that are supposed to be used in heart failure. Try to bring your blood pressure down to below 130/80. Very important. If they have coronary artery disease, they need for revascularization, consider optimal medical therapy as well. Very important for your patients. As I've said, type 2 diabetes, chronic kidney disease, sleep apnea, obesity. So these are all important aspects of heart failure management that one needs to consider. I think Dr. Atiase has done the bit of prevention of heart failure in CKD with the use of SGLT2 inhibitors as well and phenylalanine. So I'm not going to belabor the point as well. And remember, intravenous iron supplementation is also another important aspect of your heart failure management if their iron levels are low. So all patients with heart failure, especially heart failure with reduced ejection fraction and heart failure with mildly reduced ejection fraction, you need to assess their serum iron levels. Don't just go by the HB. Sometimes their iron levels may be low, but HB is normal. So assess their serum iron levels. If it is low, they need intravenous iron supplementation to improve their quality of life and also reduce the risk of hospitalization. So in conclusion, heart failure is a common and deadly cause of medical admissions. We have demonstrated that about 50% of your heart failure patients will be dead in the next 5 years. It is important that you optimize their therapy to prevent this catastrophic outcome. Heart failure with preserved ejection fraction is not a single disease. There are several comorbidities, and you need to identify those comorbidities and try to deal with them. Meticulous assessment and management of comorbidities is essential part of the management that you don't have to forget. SGLT2 inhibition are now recommended as class 1 level evidence A for managing heart failure with any ejection fraction. And that the emphasis is mine. Heart failure of reduced ejection fraction. Now SGLT2 inhibitors have class 1 level of evidence A recommendation. Mildly reduced ejection fraction, the same, class 1. Preserved ejection fraction, the same. So across the spectrum, when it comes to SGLT2 inhibitors, you don't even need to know your ejection fraction. They will still benefit. If you are in doubt, always refer to a cardiologist for proper assessment and management. Thank you very much.
Wow, indeed, this has been a very knowledgeable session. I would like to take this opportunity to really thank both speakers for the comprehensive education on type 2 diabetes, risk of kidney disease and cardiovascular disease and diabetic kidney disease, and as well as EMPA kidney data, and also the heart failure comprehensive discussion right from diagnosis and management of heart failure with reduced ejection fraction, preserved ejection fraction, and even the mid-range ejection fraction, as well as a dive into all the Empower program studies, right from EMPA-REG to EMPULSE to EMPERA preserved and EMPERA reduced, as well as the other SGLT2 inhibitor trials. This has been a really, really great session from where I stand. I believe that even the participants have been listening in and their knowledge has been empowered on these two very important topics. And I think this is evident even from the questions that are already in the chat box. So I'm going to welcome our hosts to post the questions, and then the speakers can respond. On to the first question. I think this can go to either of the speakers. What are the long-term side effects of SGLT2 inhibitors? Maybe we can start with Dr. Atiase as Dr. Agyekum takes a glass of water. Thank you. What are the long-term side effects of SGLT2 inhibitors? If Dr. Atiase has stepped out, perhaps Dr. Agyekum, you can take up. Yes, Dr. Atiase is here.
Sorry, my line dropped again.
Sorry about that.
Apologies, my line dropped. What are the long-term side effects of SGLT2 inhibitors? Well, as you may know, you know that SGLT2 inhibitors are relatively newer agents. So when we talk about long-term, I don't think we have, I think time will tell. But so far in the past, when did EMPA come out? Is it, Karen, what's it, 8 years, 7 years? I'm not too sure. I don't think we have any long-term side effects noted. Most of the side effects we know are acute side effects, UTIs, narcotic infections, the risk of euglycemic ketoacidosis in patients who probably need insulin but are given SGLT2 inhibitors for control. So you must choose your patients well. I think for the long-term side effects, I guess time will tell. Others can help me if they know any side effect, but that would be my answer to that question.
Oh, that is, yeah, I agree with you. They haven't been used for that long to have long-term
Yeah.
side effects, but we tend to have this. Like, I think the main things we mentioned are UTI because of the glucose excretion in the urinary tract, and sometimes fractures that may occur. But apart from that, I don't know of any long-term side effects. Thank you.
Thank you for that. On to the next question. So please, what is the right dose of metformin for chronic kidney disease patient with an eGFR of 45? I understand that below eGFR of 30, you should discontinue metformin because of the risk of lactic acidosis. Maybe Dr. Atiase? Yes.
Yeah, the guidelines, and I think for most of us, way before even these guidelines, we knew that the risk of lactic acidosis is high, and especially when the kidney function is deteriorating. So it is suggested that below 45, it's time to reduce your dose. If you are on, let's say, 1,000 twice a day, it's time to do maybe 500 twice a day or 500 daily. Sometimes it depends on the patient. Is this somebody who will be coming for reviews? I've had patients who have disappeared for 3 years and appear at some point, and now their eGFR is 15 and they are still on the dose we maintain them on. So it depends on the patient. If you think this is a patient you may not see in a while, maybe even at 45, you consider reducing the dose. But if it's a patient who comes for routine checkups, then we do below 45, we reduce the dose. I hope I've answered the question.
Yes, you have. I hope so. I hope the one who asked is satisfied. We can go to the next question. How do I get the slides and CPDs? Okay, that you will get the CPD points automatically. Please, what is the right dose of metformin for CKD patient of EGFR of 45? I understand. Okay, I think this one has been answered. The next question. This has been answered. So on a district where one cannot do an echocardiogram, what are the other indications for starting an SGLT2 inhibitor? Perhaps Dr. Agyekum.
Okay, thank you very much. Yes, I know a lot of the districts you cannot do echo, but as I said, if you are sure of the heart failure diagnosis, you don't need ejection fraction to start SGLT2 inhibitors. They work whether you have reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction. So if I go specifically by your question, but you need to be able to make a diagnosis of heart failure, be sure that you have the diagnosis correct. Whatever it is, you will need echo at some point. So you also need to assess the cardiac, because there are several other parameters that you will get from the echo. Does the person have valvular heart disease? Does the person have other conditions that may be amenable to treatment? So whatever you do, you get a diagnosis of heart failure, then get them to do echo at the next level where they can have echo done. But specific to your question, you don't need a ejection fraction to be able to take a decision on SGLT2 inhibitors. Thank you.
Thank you very much for that. Next question. Where does furosemide stand? Dr. Agyekum again.
It still stands very tall along the line. Whenever your patient is congested, you need furosemide. We don't count it as one of the 4 pillars because it depends on the patient's congestion status. If the patient is congested at any point in time, you can prescribe furosemide. It's not just furosemide. Diuretics are important in the management of heart failure. But if they are not congested, don't just put them on furosemide because you think furosemide is going to benefit them. No, it is only for the relief of congestion. Thank you.
Fantastic, thank you. Thank you for the presentations. Where are we on the use of sotagliflozin in the management of heart failure?
Where are we? The guidelines have not recommended sotagliflozin for now. So for now, it is not one of the, if you look at the American Heart Association, you look at the European Society, the Canadians, all of them did not recommend sotagliflozin. So for now, the 2 SGLT2 inhibitors that are recommended for use in heart failure are empagliflozin and dapagliflozin. Thank you.
Thank you. Thank you for that question and answer. What is the role of imaging in heart failure diagnosis?
I think we've mentioned this already. So yes, heart failure largely is a clinical diagnosis. They come with a syndrome, signs and symptoms consistent with that, but you also need objective evidence of structural or functional abnormality of the heart. And that objective evidence is obtained from echocardiography, which is the most common one we all use. Sometimes you may need to do cardiac MRI. Sometimes you may even need to do coronary angiography, depending on the patient's specific characteristics. So imaging is still very important and plays a key role in your total evaluation of patients with heart failure. Thank you.
Great, thank you for that. What is the approach to heart failure drugs in patients with low blood pressure? Good question.
I would have been surprised if this question didn't come, because everywhere I've done heart failure presentation, I get this question. People are worried about the blood pressure. There are two approaches to here. There are those who say low blood pressure because the blood pressure is about 110/70 or over 60. For me, that is not a low blood pressure. That is a normal blood pressure. And so you don't need to stop your heart failure medications when your patient is on your heart failure medications and blood pressure is 100/60. Keep on the heart failure medication. You know, the medications are supposed to sort of counterbalance the vicious cycle that has been set by the heart failure. So until you are able to optimize your therapy and break that vicious cycle, you are not going to get your cardiac output up to be able to get your blood pressure up. So you need to keep them on those medications. However, if a patient is acutely admitted, for instance, and the person is hypotensive, then you cannot start a lot of these medications because the blood pressure is low. So all the studies that were done, you realize that they say that patients should not be on inotropic support for you to use these agents. So if you are going to use SGLT2 inhibitor or ACE inhibitor or ANI, patients should not be on inotropic support. So if your patient is acutely ill in hospital and still on inotropic support, that is not the time to start either SGLT2 inhibitor or any of these antihypertensive medications, anti-heart failure medications that can also reduce your blood pressure. I hope I've been able to answer you. Thank you.
Yes, you have. Thank you very much. SGLT2 inhibitors cause an increase in creatinine or worsening of eGFR. At what point to recheck renal function after initiation, and when do you stop an SGLT2 inhibitor?
Well, I think we showed in one of the slides that there's an almost an expected decline in eGFR. However, if you have more than 30% increase in serum creatinine or more than 25% drop in EGFR, you may want to consider holding on, hydrating the patient, and maybe restarting. Typically, we would say consider rechecking these parameters within 2 to 4 weeks of initiation, and then you decide. I have found, however, that a lot of our patients are not hydrated well enough, and often just by encouraging hydration, that trend, sort of recovers almost quickly. Thank you.
Okay, thank you very much. How low can your eGFR be before you can't use an SGLT2 inhibitor? I think this one might have been answered, but
yeah, I think that one too will be below the EMPA range. They went as low as below 20, anything above 20, isn't it? Below 60 to
yes.
20 current. Yeah, so up to 20 eGFR of 20 is acceptable, or has been documented to be safe.
Okay, thank you. Will combination of a GLP-1 and SGLT2 inhibitor improve glycemic outcomes and renal outcomes?
Yes, indeed. There are studies that have shown GLP-1 receptor agonists and SGLT2 in combination, and the outcomes are almost synergistic. And yes, so if you look at the guidelines, they'll say the diabetes guidelines for hyperglycemia in people who have established atherosclerotic cardiovascular disease or kidney dysfunction, you do your SGLT2 inhibitor first. If heart failure predominates, then you can add a GLP-1 receptor, or vice versa if it's atherosclerotic cardiovascular disease. So I think, yes, if a patient can afford these two in combination for both renal, glycemic, weight loss, and cardiovascular outcomes, yes, it's desirable.
Thank you. What are the diabetic phenotypes and what are their diagnoses?
Well, in the past, the diabetic phenotypes that we were all taught, if you are old school like me, was type 1, type 2, gestational diabetes, other types, which included drugs, endocrinopathies, and the like. In recent times, however, it's been shown that This does not describe adequately the different types of diabetes that we have around now. And so the phenotypes have, I'm sure whoever has asked has read, the phenotypes have changed slightly. They describe 5 phenotypes. One, severe autoimmune diabetes, which would cover some type 1s and what we would call latent autoimmune diabetes of adulthood in the past. Then we have the severe insulin deficient diabetes, which is classically the type 1 diabetes, low BMI, low insulin. Then we have the severe insulin resistant diabetes, which we know as type 2. Most people will know that as type 2. Then we have the obesity-related diabetes, which has a slow progression, but is also there. Then we have the age-related diabetes. These are often mild. The obesity-related diabetes and the age-related diabetes are often slowly progressive. So it's still the same type 1, type 2, but they've been described a little bit differently. And so, they cut across. But I think that the new teaching is that these describe it even better than the type 1, type 2 gestational diabetes and other specific types. Thank you.
Thank you for that. There was a part about their diagnosis, so maybe you can just highlight the HbA1c cutoffs for maybe type 2.
Well, the diagnosis, as far as I know, the cutoffs are, if you have symptoms and signs and symptoms of hyperglycemia, then a fasting plasma glucose of 7 or a postprandial of 11.1 or an HbA1c of 6.5. If that's what they mean, then yes. I don't think it changes that much.
Okay, thank you for that. What are the absolute contraindications for SGLT2 inhibitors?
Well, for now, I think that the absolute contraindication will be very low EGFR, as we've discussed earlier. But also in the past, some people, when SGLT2 inhibitors came, and it's off-label, some people use it in type 1 diabetes who are not very well controlled. But I think that's dangerous, especially when patients realize that they will get a glycemic control. So, so type 1 diabetes will also be an absolute contraindication. Remember that even in type 2 diabetes patients who require insulin, they've come to the point where they have no insulin, they've lost insulin reserve. You do not want to. Can you hear me?
Yes, we can hear you very well. Sorry, we might have lost Dr. Atiase.
Okay, so basically, what she was saying is patients who are prone to ketosis. So if you have type 2 diabetes and you don't have any insulin, you just get some ketotic conditions, it is not good to use SGLT2 inhibitors. Make sure you get them out of ketosis. People with UTI or recurrent UTI, it is not a good idea to put on SGLT2 inhibitors as well. Basically, and of course, if the systolic blood pressure is less than 90 millimeters of mercury, usually we do not recommend that you put those people on SGLT2 inhibitors as well. Thank you.
Thank you very much for stepping in. Excellent presentations. Any interventions to make these drugs affordable and available so a lot of patients can benefit from them?
This is up to BI and other colleagues. Making the drug available and affordable.
Yes, that is something that comes up many times. I think that will be taken back to the company as a feedback. Next question. Welcome back, Dr. Atiase.
Yeah, my line dropped. Sorry about that.
Sorry. Thank you for sharing this insightful information. My question is that in the studies that were cited, were Blacks included in the study samples?
Usually, it's one of the major problems we have. For a lot of them, the black presentation is quite small. You get about 5% black representation. So these are, and this has been one of my major advocates around. Let's get some of these studies replicated in Africa, get a lot of patients, and then we can also tell our own story. For now, what we have is what has been done in those places. If you look at, I think the two live studies I started there, black representation were just about 5% of black patients. Thank you.
Thank you for that. I think that is a call to researchers like our two presenters to start real-world evidence studies in their respective clinical practices. Can we use SGLT2 inhibitors in a decompensated heart failure? I think that might have been answered, but Dr. Agyekum, you can say it again.
Yes, as I said, if the patient is not on inotropic support, the patient is stabilized, yes, you can use your SGLT2 inhibitors and other heart failure medications. Note that in acute heart failure, if the patient is still on inotropic agent, then you cannot use. But once you get them out of inotropic agent within 24 hours, you can still start. And that is what the EMPA study also tried to show, and the soloist trial, they all were used in patients who had acute decompensation of heart failure, but they were not on inotropic support. Thank you.
Thank you for that. Thank you for the presentation. Why is atenolol not recommended in HFrEF?
Because it has not shown benefit. We are talking about evidence-based practice. So for evidence-based practice, you look at drugs and medications that have shown benefit, reduction in death, reduction in hospitalization, reduction in composite outcomes, improvement in quality of life. Atenolol or propranolol, they have not shown that benefit. The only 4 beta blockers that have shown benefit in this line is carvedilol, metoprolol succinate. Even metoprolol is not all metoprolols. The metoprolol tartrate, a study was done with metoprolol tartrate. It did not show benefit. So we do not prescribe metoprolol tartrate in heart failure. It's metoprolol succinate. That's the extended release metoprolol. Then you have bisoprolol and nebivolol. So those are the 4 drugs that have shown benefit and therefore qualify for evidence-based practice. Thank you.
Thank you for that. We are approaching the top of the hour, so maybe just the last 2 questions. Thank you for this wonderful presentation. First question, please, can we have an idea about the cost of any of the SGLT2 inhibitors for 1 month duration? I think that's a question for me, and unfortunately our sales team is not present in this medical session, so I'm going to request for the host to take the email address of this person asking this question, and we will give them an answer about the cost. Is there any other question in the background? What is the approach to heart failure drugs in a patient with low blood pressure? I think this has already been answered. Any other question? What is heart failure with improved ejection fraction?
Okay, so that is a new category that was introduced with the ESC guidelines, heart failure with improved ejection fraction. What that means is that you have patients with heart failure with reduced ejection fraction, that is ejection fraction 40% or below. You start guideline-directed medical therapy, and then you re-echo them maybe in 6 months, in 1 year. Their ejection fraction has now moved from, let's say, 20% to 45% or 20% to 50%. These patients cannot be reclassified as heart failure with mildly reduced or heart failure with preserved ejection fraction. So they are said to be heart failure with improved ejection fraction. And the recommendation is that you continue with the guideline-directed medical therapy. Don't de-escalate because their ejection fraction has improved. Thank you.
Fantastic. Thank you for that. This might be the last question. Please, is there any risk of hypoglycemia in a non-diabetic client with heart failure on an SGLT2 inhibitor?
I have my
You can take it up.
diabetologist here, so I'll let her talk.
I think that the answer will be no, because remember that even for patients with diabetes, SGLT2 inhibitors were considered very low risk for hypoglycemia. And indeed, if you had to choose a low risk drug in terms of hypoglycemia as one of the drugs to consider, remember the way it works. Once your glucose gets above a certain threshold, then your kidneys open up and you excrete the glucose. However, when you are using it in heart failure, you're not using it for diabetes. You're not using it because, and Dr. Agyekum showed us many mechanisms by which that may occur: natriuresis, oxidative stress, fibrosis. So, for heart failure, we are not using it because of glucose, and the mechanism by which it's effective in heart failure is not in the glucose pathway where the kidneys open up for glucose. So I think, yes, the answer will be no. The risk is very low.
Great. Thank you for that. We will consider this to be the very last question. Once again, I would like to really extend my gratitude to the fantastic presenters we've had this afternoon into the evening. We've learned a lot. I can say I have personally really learned a lot. And I believe that the participants are also going back really empowered to give their patients much better clinical care, better empowerment in diagnosing heart failure, in identifying risk of cardiovascular disease and chronic kidney disease, and starting this guideline-directed medical therapy as early as possible for their patients. So at this moment, I will allow everybody to leave, and remember to fill in those questions from the link that will be shared in the chat box. Thank you once again very much. Have a lovely evening, and wishing you all the best in your various practices. Have a good evening.
Thank you, Karen. Thank you, Dr.
Thank you.
Atiase.
Thank you, Francis. It's been a pleasure speaking with you.
Thank you.
Yes.
Thank you,
absolutely.
and bye.